We live in an age of measurement. We quantify our steps, we track our sleep, we count calories. It seems natural then that medicine would try to do the same with suffering. We want to understand it. We want to conquer it. To do so, we believe we must first measure it. So we ask the question, how much does it hurt? We create scales. We create scores. We turn a deeply personal, human experience into a number. This impulse is understandable. It comes from a desire to help, to make objective what feels chaotic and subjective. But pain is not like temperature. It is not like weight. It is a sensation. It is also an emotion. It is a signal from the body. It is interpreted by the mind. It is filtered through memory. It is filtered through fear. It is filtered through hope. A construction worker with a high tolerance for physical hardship might describe a broken bone differently. A violinist might see the same injury as a career-ending catastrophe. The experience is not just the physical signal of a fracture. It is the entire context of a life. The central question then becomes not just, can we measure suffering, but should we? And if we do, what do we lose in the translation? Consider one of the most common tools in medicine, the Numeric Pain Rating Scale. It is deceptively simple. A doctor or nurse asks you to rate your pain on a scale from 0 to 10. 0 is the complete absence of pain. 10 is the worst pain imaginable. The scale is easy to understand. It takes only a moment to use. It provides a data point that can be neatly entered into a patient's chart. This number becomes a vital sign. Blood pressure, heart rate. It is a quick and efficient way to gauge a patient's distress and to track the effectiveness of an intervention, like a dose of morphine. The benefits of such a simple system are immediately apparent. It provides a baseline. If a patient arrives at the emergency room reporting a pain level of 8, and after treatment reports a 4, we have a clear indicator that the intervention is working. This number helps teams of caregivers communicate effectively. A nurse finishing a shift can tell the incoming nurse, Mr. Jones in room 204 was at a 7, but the medication brought him down to a 3. It creates a standardized language that cuts through ambiguity. For researchers, aggregating these numbers from thousands of patients can reveal which painkillers are most effective for a specific condition. But medicine's ambition to quantify does not stop at immediate sensation. We have also developed tools to measure the impact of illness over time. One such tool is the QALY, the Quality Adjusted Life Year. This is a far more complex and controversial metric. The QALY attempts to combine the length of a life with its quality into a single number. 1 year of life in perfect health is worth 1 QALY. A year of life with a disability or chronic illness might be valued as 0.7 QALYs. Or it might be valued as 0.5 QALYs, depending on severity. This calculation turns the abstract concept of quality of life into a concrete figure. Health economists and public health officials use QALYs to make difficult decisions. They use them to compare the cost-effectiveness of different treatments. For example, should a limited healthcare budget be spent on a new, expensive cancer drug that extends life by 6 months with significant side effects? Or on a program for hip replacements that dramatically improves quality of life for many elderly people? The QALY provides a seemingly rational mathematical basis for allocating scarce resources. It attempts to answer how to achieve the greatest good for the greatest number using the cold, hard language of data. The power of turning suffering into data cannot be dismissed. Numbers have a unique ability to make the invisible visible. A single patient complaining of pain might be overlooked, but when data shows hundreds of patients in one hospital wing reporting high pain scores, it signals a systemic problem that demands attention. Data can reveal patterns that individual anecdotes cannot. It can highlight a ward that is understaffed. It can highlight a procedure that requires better pain management. It can highlight a doctor whose patients consistently fare better or worse. It transforms personal troubles into public issues that can be addressed. Furthermore, data is a powerful tool for advocacy. It is one thing to say a disease is debilitating. It is another to present a study showing it reduces quality of life by 50%. It can cost the economy millions in lost productivity. Numbers speak the language of policymakers and administrators. They provide the, hard evidence often required to justify funding for research. They provide the evidence needed to approve a new drug. Section 4. The shadow of the number. What data conceals? For all its benefits, the act of reducing a human being to a number carries profound risks. The greatest danger is that the number can obscure the person. Pain is more than an intensity score. It is interwoven with anxiety about what the pain signifies. It is shaped by a person's culture. It is shaped by a person's past experiences with trauma. A score of 6 on a pain scale tells us nothing about the patient's fear that the ache in their chest is a heart attack, or the despair of a person with chronic pain who has been at a 6 every day for the past 5 years. The number is a silhouette. It lacks the texture, it lacks the color, it lacks the detail of a real person's life. This simplification can lead to poor medical care. When a system is designed around numbers, it incentivizes treating the number, not the patient. A doctor might see a patient with a high pain score and immediately prescribe a strong opioid, achieving the goal of lowering the number. But this approach might miss the underlying cause of the pain, which could be psychological distress, social isolation, a misdiagnosed condition. The focus on the metric can lead to a kind of tunnel vision, where the rich diagnostic details of a patient's story are ignored in favor of a quick, quantifiable fix. Trust erodes when patients feel they are being treated as a data point rather than a person. The ethical implications become even more stark when we consider metrics like the QLI. These scores explicitly place a different value on different lives. A year in the life of a healthy young person is calculated as being worth more than a year in the life of an elderly person with multiple chronic conditions. When used to allocate resources, this can lead to decisions that are deeply discriminatory. An expensive treatment might be denied to a disabled person because their potential quality of life gain is calculated to be lower. This is a moral minefield. It risks codifying the biases of society into a seemingly objective formula, marginalizing the very people who may need the most care. Ultimately, an over-reliance on numbers creates a dangerous illusion of objectivity and precision. The feeling of pain or the quality of a life are not physical properties that can be measured with the accuracy of a ruler. They are subjective. They are fluctuating. They are deeply personal. Assigning a number to them does not make them any less so. It merely hides the complexity and uncertainty behind a veneer of scientific authority. We can become so confident in our data that we forget it is a crude approximation of reality. We forget to ask the simple, human questions. What is this like for you? What are you most afraid of? What matters most to you right now? You know? Section 5. A humane calculus. Merging numbers and narratives. The path forward is not to abandon measurement altogether. To do so would be to discard a powerful tool for understanding and improvement. The challenge is to use our tools with wisdom, humility, and a profound respect for their limitations. The first step is to treat numbers as the beginning of a conversation, not the end of it. A pain score of 8 should not simply trigger a prescription, it should trigger a question. An 8? That sounds terrible. Tell me more about what that feels like. Where is it? What makes it worse? What are you worried about? The number should be a key that unlocks the patient's story. We must build systems that accommodate both data and narrative. A medical chart should have a place for the pain score, but it should also have space for a nurse's note that says, "Patient is fearful about being able to care for her children." Patient seems much more comfortable after his wife visited. We need to train doctors, nurses, administrators to be bilingual, to speak the language of data and the language of human experience. This means valuing the time it takes to listen as much as we value the efficiency of a checklist. It means recognizing that what can be counted is not the only thing that counts. When making decisions on a larger scale, especially those involving metrics like QLEs, we must embed ethics directly into the process. We should use these numbers as one piece of information among many, alongside input from patient advisory groups, ethicists, community leaders. The data can tell us the potential cost-effectiveness of a treatment, but it cannot tell us what a just and compassionate society owes to its most vulnerable members. Transparency is crucial. The public has a right to know how these calculations are made and to debate whether they reflect the values we hold as a community. These decisions should never be hidden behind a black box of algorithms. Ultimately, true care exists in the space that numbers cannot reach. It is found in the clinician who pulls up a chair instead of standing by the door. It is in the willingness to sit with a patient's uncertainty and fear without rushing to a solution. It is in the simple act of acknowledging a person's dignity beyond their diagnosis or their score on a chart. We must strive for a humane calculus, one that balances the clarity of data with the richness of stories. We must use our numbers to improve systems, but we must rely on our humanity to care for people. For in the end, suffering is not a problem to be solved with data alone, but a human condition that calls for connection, empathy, and grace.